I'll hit record. All right. Well, welcome everyone. And Esther, you want to have call on whoever's going first?
Okay, sure. Chun Rai, do you want to go first? So we met during the week, last week, and then we went over some over his presentations and we practiced. So hopefully this will be educational for everyone. I think it's a very difficult topic, but he did a very good job with good pictures and good gross findings and overall correlation with pathology and clinical. I'm excited.
Yeah.
Hello everyone. Today I want to present about my case. I picked up about uterine tumor. Hello everyone. Hear me?
Yes.
Okay. Clinical information. Females 45-year-old with abdominal pelvic pain, metrorrhagia, difficult urination for the 2 weeks. Ultrasound finding to show one mass in uterine cavity with hyperechogenic heterogenic. Her size is around H diameter with posterior infiltration. No CT scan, no MRI. But pregnancy test, uterine pregnancy test positive. Clinical impression should be endometriosis. Sure. Before fisheries, clinician confirm beta HCG to show very high. Is 4,240 milli IU per milliliter. During total hysterectomy procedure, clinician capture for me hysterectomy border of uterus is a smooth borders, but bulging like the balls. When he cuts to show the hemorrhage necrotic inside uterine cavity. Hemorrhage with necrotic area. After surgery, clinician control again beta HCG to the go down. He sent me total hysterectomy specimen. I receive total hysterectomy the uterine copper smooth borders with a puncture, surgical puncture. Here, anexa tumor, anexa here. The specimen show intrauterine cavity necrotic mass with hemorrhage. Cervix looks like normal. Anexa is looks like normal. I cut the uterine specimen to show here normal cervix. This is area necrotic area, and some posterior wall infiltrations, yeah, and necrosis, hemorrhage. The necrotic area I collect to show hydrophic village or cluster, look like cluster grapes with bullying village. For anexa tumor is normal. For into uterine copper, the size is increased size with necrotic mass inside uterine cavity book around 4 centimeter, with bulgy bloody tissue villus, hydrophic villus. All smoke villi more than 2 millimeter in diameter. Villus edema looks like grapefly. Villus, most of villus is the semi-transparent vesicle. I try to find placenta structure or fetal part, but not seen. For micro cross-section differentiation diagnosis, I think endometrioid carcinoma or sarcoma, choriocarcinoma, malignancy, complete or partial, placenta retention, endometrial hyperplasia, or adenomyosis, etc. In microscopic, I saw multiple choriovelus edema, but the smooth border in villus node intravillus mesenchymal stromas is the edemas with some proliferative stroma cell or syncytotrophoblasts or cytotrophoblasts. Here, proliferative a capillary choreo to this picture to show the choriovelus edema with a little proliferative syncytotrophoblast or cytotrophoblast. It's a hemorrhagic maternal blocks. This is a picture to show proliferative cytotrophoblast. A little bit, not so much more, not ATP. This picture the same, proliferative. Syncytotrophoblast, cytotrophoblast is a little bit proliferative or atypia. Some choriovelus invade to the intrauterine myometrium, invade to myometrium with the trophoblastic proliferative intramyometrium. This picture to show a little bit proliferative or ATP syncytotrophblast. Is the mitosis syncytotrophblast. So a little bit, not more, much more. Some mitosis feature to show here, some mitosis. So, but not much. Endometrium gland present intramyometrium here. This is a endometrium gland and endometrium stroma present in myometrium. For the summary in microscopic finding to show villus inflamed, villus edema, trophoblast proliferative, stroma proliferative, hyperplasia with example syncytotrophblast proliferative, mitosis little, capillary proliferative. There are some hydrophic villus or trophoblastic proliferative inside myometrium. Endometrium gland present intramural. But feature a fracture or tissue not present. For differential diagnosis in case should be invasive mole, cholangiocarcinoma, or etc. For the invasive mole is cholangiovirus invade to the vessel or endometrium, intramyometrium. For the cholangiocarcinoma, it has proliferative or much more atypical syncytotrophoblast without villus, choriovilus, without present. For if the difficult to the differential invasive mole or partial mole cholangiocarcinoma should be confirmed. IHC P57. In final diagnosis is complete hydrotic mole with adenomyosis. I want to review about normal villus development. In the first symmetries, villus intravillus is clear. Stroma is clear, so not loose. The villus lined into free two layer. Outside layer lining by syncytotrophoblast. Inner layer lining by cytotrophoblast. Mesenchymal stroma here. Here capillary channels. For endothelial cell here. For the third symmetry, villus is then to make a mature. Inside the villus is proliferative capillary for the exchange gas or the nutrition received from mother. Thank you.
Thank you. I know it's a very complicated topic and we don't encounter it very much in my practice. We don't have an OB-GYN, OB here. So I thought it was a very interesting case, and thank you, Chunrai, for sharing.
Thank you, Rosa.
Do a lot of people encounter placenta pathology in their practice? I know Dr. Singh's hospital probably has a lot.
I'm not lies.
Yeah. Good morning. So we have a lot of placenta. However, we have a separate division of perinatal. So
Yeah. So yeah, a lot of complicated placentas and these molds and trophoblastic disease gets signed out by perinatal pathologists, and they have special training also. Thank you. So maybe we can move on to the next presentation. We have Tian.
And just for the learners, don't be afraid if you don't feel like you've learned this. This is actually a topic that is covered in I think module 2. So it's not really even touched on very much in module 1. But I think a great case, and it is always challenging to differentiate the invasive versus choriocarcinoma issue. I don't know what the standards are that you use, Esther, but I mean, we've had a number of cases where you do have that combination of a lot of syncytial trophoblastic proliferation and hemorrhage, and then you maybe find one little villus or two villi, and that can be just so, disconcerting. What do you call it, one or the other? But I think the bottom line is that the treatment usually is not dissimilar, whether you call it choriocarcinoma or invasive mole. So from that standpoint, in terms of patient management, which is, I think, always a good thing to be thinking about, the difference is not highly significant.
Thank you.
Thank you.
So Tian, you ready for your presentation?
Yes, I'm ready. I will share my screen. Okay. Do everyone see my screen?
Yes.
So, hello everyone. My name is Dean. So today I will present a case in GYN module. So we have a patient, 70 years old woman, came to the clinic because of postmenopausal bleeding. Her endometrial keratin show fragment of carcinoma with squamous differentiation and papillary architectures. The ultrasound show enlarged uterus with increased endometrium thickness and lesion in cervical canals. She is known to not have any history of cervical pathology, but we don't know if she didn't do the cervical screening or she did it outside of our system. She's then referred to our hospital for hysterectomy. On evaluations, her cervix were normal. So we have a questions here like if the squamous cell carcinoma is from the endometrial itself or from the cervical origins. Given by her age and the normal cervix, endometrial squamous cell carcinoma could be the reason, but this condition is very rare. However, even though her normal cervix, she have a normal cervix, we couldn't rule out the cervical origins of this carcinoma. This is her abdomen CT scan. We can see a bulky border of the uterus, and also we don't see the line, the thin strip lining that we usually see in postmenopausal women. And also there's a lesion in the cervical canal. So after the hysterectomy, we have the surgical specimen. On your left is the endometrium section, and on the right is the cervix. On the endometrial sections, we can see the endometrial glands, which are kind of dilated and cystic. So we can call it atrophic endometrium. But on the other side, we can see the exophytic tumor in the cervix sections. We can see the smooth border of the carcinoma compared to over here is the nest of the tumor cells. So based on these pictures, we can say that her carcinomas may be from the cervix. To look a little closer to the cervix, we can see clearly a very smooth border of the epithelium, and also there's no maturation in her squamous layer. And compared to the normal cervix over here, we can see that the nuclei here was overlapping each other and have a very high NC ratio. The white arrow show mitosis and the black arrow show apoptosis. And you can see there's scatter of mitosis and apoptosis throughout on the layers. This is another picture of the cervix to see the progressions from the in situ to the invasive. And we can notice also there's a paradoxical maturation over here, and on the bottom right is necrosis. To talk about paradoxical maturations is where the squamous cell major that they usually don't, like in this situation. And we call it paradoxical because Compared to the top layer, it is poor differentiation, but it's major over here with some eosinophilic component. The next of the neoplastic cells, we can also see scatter of the mitotic figures. When we go back to the endometrium section, we can see this tumor is invading down the muscles. Compared to over here, this area, we have papillary architectures. So we assume that her first biopsies will have these same pictures with the fibrovascular core that all over the place. So it could be the reason why her endometrium were thick and fill up the uterine cavity. These pictures, I want to show that this tumor is invaded on the layers of the uterine. So from the endometrium to myometrium and serosas. We can also see the leiomyoma over here, which is a very hard and well circumscribed nodule. And we believe that because this nodule is very tight and condensed, so the tumor cell cannot invade through the nodule, they have to go around it. This is another picture show that this tumor already invade into the vessel, the blood vessel over here and the lymph vessels on the right. This is the picture of the fallopian tube. We can see the plica that fill up the lumen, and the tumor is already invaded into the surrounding connective tissue of the tube. This is another section of the ovaries. You can see the corpus applicans that we usually see in postmenopausal women and very many small coil vessels in the hilum. And we can easily notice that there's neoplastic cells over here, which we can say that the tumor already invade the ovaries. So we can come to the HC stain. In this case, we did the P16 and the P40. P16 is the P16 we usually know as the tumor suppressors proteins, and it usually known to be inhibit cyclin dependent kinase. However, we can use P16 to be a surrogate marker for the oncologic HPV infections. And we can see here is a diffuse positive pattern, although it's abruptly stopped, but we can still call it positive. And on the left is P40, which is a nuclear stain for squamous differentiations, and this is all a diffuse positive too. So to talk more about P16, I want to talk about how we interpret P16 results. So we can call it positive when we see strong and continuous nuclear expressions, or if we see nuclear and cytoplasmic staining, but have to involve the basal and the parabasal layers. And if it's negative, we can see they have only stain the cytoplasmic, like over here, or they just show patchy pattern or a very weak diffuse staining. In this case, we also do the HBVH. So I want to talk a little more about what is HBVH. So this is HBV in situ hybridizations. We detect HBV DNA and RNA by using the label nucleic acid group, and many research show that these tests have a higher specificity and accuracy compared to using H&E alone. So in this patient, we have a positive HBV. In conclusion, this patient have an HBV-associated squamous cell carcinoma of the cervix. This is a very common type of cervical carcinoma, and it's also a very common type of cancer and the cause of mortality. Most common cause is HBV type 16 and 18, and usually seen in women from 40 to 54 years old. But thanks to cervical cancer screening programs, the prevalence has decreased up to 75% over 50 years. But however, we still see in women who fail to receive screening or follow-up their screening result as we seen in these patients. So this is the end of my presentation. So anyone have any questions?
Thank
So I have
you.
a question, Tien. Why she was so old, age 70.
Yes.
Is that unusual, or what are your thoughts on that? So in many institutions, they don't screen for cervical cancer after 65 or 70.
Yes, I have a same questions when I see this case. So it's not common for a 70 years old woman to have this carcinoma in her cervix, but because we didn't find any history of her pap smear in the past, so we didn't know that like in the past she have any result for the pap smear. And from as far as I know from the screening program in the US, so if the patient they have normal pap smear in the past and they are over 70s, we don't do it anymore. But in this patient, we don't have any history, so I think that we still need to like have some pap smear for her for the screening.
Yeah, that was my point. I think in my clinical practice, the most common presentation for cervical cancer is a woman who has not been regularly screened. And so an older patient who hasn't been screened, you still have to think about the common diseases.
Yeah.
Yeah. I think it's a very interesting case. Tien, so one question, were the lymph nodes removed and were they involved?
Um,
Do you know that status of
Dr.
it's
Jung, can
okay.
you help me?
So this is a case I shared with her. The lymph nodes
Ah,
were, lymph nodes were
okay.
removed and they're negative.
Oh wow. Yeah, so it's a very it's not a common presentation. Other thing odd was so there is no cervical deep invasion in the cervix, but there is deep invasion in the uterus.
Hmm.
Yeah.
So that is also unusual. Usually the cervical tumor spreads in the cervix, involves the
Yes.
paracervical tissue, often high stage presents with hydronephrosis and all that. But this went up into the uterus, involves the endometrial cavity, has deep myometrial invasion. So the pattern of spread is also more like endometrium. It's involving the tubal vessels and ovarian hilar vessels. So it's an unusual case. So, but HPV-ish was done, so that's interesting. It is actually related to the HPV. So that proves that it started in cervix but spread upwards into the
Yeah.
endometrium. So great case, unusual
Thank
case,
you.
and great presentation. Nice pictures. I love the arrows, and they show up at the right time. Yeah, thank you.
Thank you. Do anyone have any questions?
So here's another question. Would the vaccination program have prevented this case?
I think they have the HPV vaccine. They have 3 doses for both women and men from I think 10 or 12 years old that they can get the vaccines. And
But
they
does that,
also have different type of vaccines, like they have like six type or nine type something. Like they will cover the high risk HPV, but not all.
yeah, I think that's the point, is that you have to recognize that the vaccines cover the most common types,
Mhm.
and but not every potential oncogenic HPV type is included in that vaccine or in the vaccine options. And especially for women who may come from a different area, geographic area, um, the vaccine may not, so the HPV types that are prevalent in some areas are different from the HPV types that are present and most commonly included in the vaccine. So both of those issues can make it a little challenging. And the other issue I think sometimes is that even in some older women, there is a role for the vaccine, either as an adjuvant treatment option or as a further prevention in some situations. And that's sort of still investigational, but I know in our institution, they are starting to look at those options a little bit more carefully in some patients.
So that's all the presentations we have for you. Was there any questions in the modules or any difficulties when you did them this week, last 2 weeks?
Either the GYN module or the breast modules, any questions are valid.
Thinking about next week or the following session, 2 weeks, if you have ideas of what you would like to cover because you've been struggling with that, we don't have to necessarily stay on topic. We can jump back to breast. If there's something you guys want to cover.
And this is a great, safe and open environment. We have great mentors, Dr. Hassel, Dr. Singh, Dr. Mazzano. You can practice your presentations. You can make it for next time and use it all over again. So feel free to, reach out to all of us.
Yeah, so if you haven't presented a case yet and you'd like to, please let us know, and we'll make sure that you can find a case like this case that Esther found, and work up a good presentation. And as Dean said to me before many of you got on, she learned a whole lot from this presentation that she wouldn't have learned quite as easily otherwise.
And I had to go back to relearn the molds because I need to talk with Chonrai, and he taught me a lot also. It's a case that I don't think about and you don't see like for years. So I want to thank him too.
Yeah, great job, Chonarai. I missed part of it, but I was telling Esther I couldn't give that presentation. So good job. That's a really hard topic.
Sorry, my picture I capture by phone, not Korean, not beautiful.
They're still educational.
Yes.
So we have about 20 minutes left. What do you want to do, Dr. Hassel? I don't have any case or slides prepared.
Kamalji, do you have anything you want to share? I can pull up some digital slides from my archive, but if you have something.
I pulled up some just basic cervix if we wanted to go over that. This is a topic that you come back to over and over and over again throughout your career, intraepithelial neoplasia. So you can't get away from it no matter what specialty you practice.
And it's the neoplasia. So the in situ components can be across, the cervix, vulva, vagina, anal. So I think it's very applicable. Something that you really
Head and
want to
neck.
have a good foundation for.
Yeah.
Well, why don't you do that, Dana?
All right. Yeah, I could share my screen. We could do it as a group, huh? 1 second. I always goof with this sharing. Hold on 1 second. Let's see. Yeah, this is it. Okay. So when you're starting out, don't forget, it's I think your first impulse is to Google everything, but you'll get a mixed picture if you start on Google. And a lot of times you'll get some great images. Actually, I did it just out of curiosity, and there was some really great images of cervical intraepithelial lesions. But the best place to start, in my opinion, when you're first starting out, is just to go to the WHO, go to the main topic. Let's see, bring it back. Start in the introduction and just read through this general introduction. Then find your topic, read through the introduction here. It will really help guide you and give you a broad overview of what you're looking at rather than just trying to go and picture match on Google. So that's the way to start. So if you have a case and you're saying to yourself, oh, I'm not sure if this is neoplastic, metaplastic, you're probably looking at CIN1 in that case. Oops, sorry, let me close that. Share any patient data. Okay. Oops. So this is a topic that people struggle with still. I still struggle with this. I think that in cytology, low-grade squamous intraepithelial lesions are 1,000 times easier to see than on histology. So get that back. If you're looking at the cervix, there's a couple of things that you should be aware of before you start thinking of neoplasia. And one of the mimics is squamous metaplasia. And so again, go to the WHO, look at what these mimics are, it has a little section. And this, at first glance, I remember being tricked in residency in a slide presentation and saying, oh, I think that's dysplastic. And you'll kind of just train your eye to recognize this metaplasia. And one of the key things, whether you're looking at cytology or you're looking at histology, is the density of the cytoplasm. So the density of the cytoplasm gives it away for metaplasia rather than dysplasia. It has this like very pink, glassy, thick look. It doesn't look glycogenated. And that is just a normal process in the cervix and other places. But this is what it looks like in cytology, and it's so much easier to recognize, in my opinion, as a metaplastic cell. And so you don't have to worry about this. This is not dysplastic. For this, when you're looking at a cell and you're trying to decide whether it's normal, what you're looking at is your nuclear to cytoplasmic ratio. Is there a lot of space still, or is this nucleus enlarged and taking up the whole cell? you're looking at density of the nucleus, and is that too dark? And here, when you're kind of first starting out, you're saying, oh yeah, it is dark. What do you mean? But it's not hideous. And when you see a high grade cell, you'll know what I'm talking about. So the size of the nucleus is just slightly enlarged over these obviously benign background squamous cells. And then the contour of the nucleus is what we're looking at. So if this is nice and smooth and it's not irregular, then you know you're dealing with a safe cell. So you can use these same principles when you're looking at histology. Let me go to the squamous cervix. Here we go. So one of the things that's a little confusing in pathology is that terminology changes. So now we are dealing with a system that says low grade and high grade. And we used to be talking about a system that said CIN1, CIN2, and CIN3. And then, so the way it's reported out, sometimes people are still using these terms, but they abide by the WHO classification of low grade, and then they will put CIN1 in parentheses on the end of the sentence or something like that. So you'll see these things in your sign out, and it can be a little confusing. Don't hesitate to ask questions like, why are we using two different terminologies? And a lot of times that's because it's historical. And clinicians are, evolving at the same time we are. When we are changing our terminologies in pathology, they've been practicing 20, 30 years and calling it one thing, and now we're changing it. So it's just kind of keeping everybody on the same terminologies. So anyway, so low grade versus high grade. Low grade is basically CIN1, and high grade encompasses 2 and 3. So the GYN experts, in my training, our clinicians wanted to know whether it was 2 versus 3. Is that still a thing in cervix?
Sometimes. I think it has to do with but not so often, but sometimes they ask. And it's hard between 2 and 3. I don't separate it out all the time.
Our clinicians, sometimes they will ask if the patient is between 25 to 30 years of age, because
Oh, interesting.
yeah, if the person is younger and we say it's CIN2, they may choose to observe. If it is CIN3, then they may go to cone biopsy.
Oh, wow. So in those cases, for our trainee groups, it's really good to be aware of those clinical management decision points where they change, because those are the cases you want to show around, right? You can't go and show around every single cervix you ever get on your desk. We're probably all averaging around 100 cases a day for sign out. That's like what your volume is. So you obviously cannot show every single case that you get, but these are the key cases, right? Those are the ones like, oh, this is really going to change the management for this patient, and I'm not 100% sure whether I would call it 2 versus 3, and the clinician's asking, they're calling. Those are the cases that you want to show around to your other attendings and get a consensus. So that's how you approach that. So when you're trying to approach the diagnosis, it can be very tricky. When you look at these nice, clean photos, it's a lot easier to start with. So if you guys probably went through the module, can identify these key things: coilocytic change, this enlarged nucleus way above basal layer. You shouldn't be seeing those. Saw another really good picture. That one we won't jump to quite yet. This one, you should never be seeing a nucleus this dark, this big, irregular nuclear contour. Shouldn't be living all the way up to this surface, right? If you're going to see a bigger nucleus, it should be way down here in the basal layer. The paranuclear halos can be pretty tricky because of glycogen in the cervix. So be careful with that. When you jump to CIN 2 and 3, it becomes a lot easier to see as an immediate recognition. Gee, this is obviously irregular. Am I going to call it 2 versus 3? This little snapshot, I think everybody would call 3 because it's just from the entirety of the epithelium. You can see that there's dysplasia involving the full thickness. You don't even need stains for this, but if you were going to stain this, which generally you do, you look for P16, as was shown in Tien's excellent presentation. I love cytology, and I'd rather look at a pap smear than a cervical biopsy any day. So I got to show you this beautiful example of low grade in cervical cells. You can see now that hyperchromasia I was talking about. If you look at this normal cell, you see that the nuclear contour is smooth, it's small, it has low NC ratio, it's kind of got this pale chromatin as compared to these really enlarged, really dark nuclear contours or nuclear characteristics. And this one even has a little bit of notching inside. And of course, the perinuclear halo and binucleation should pretty much never happen. These are all the signs that you look for low grade. And we know it's not high grade because you still have a lot of space in between the cytoplasm and the nucleus. All right, so then kind of geared up with that, I was thinking if someone was brave enough, if they want to describe this biopsy, which I thought was so good because you have a direct contrast between this piece and this piece on this side versus this side. Anybody? Dan, come on, I know you got this.
Yeah, I see that like there's no maturation in this squamous epithelium. The nuclei is kind of overlapping each other. They have high NC ratio with a very dense chromatin.
Great. Right. You nailed it. And that's exactly it. You just start by describing. And it's so uncomfortable at first, right? Because we don't do that in our normal day-to-day lives. We don't just describe things in front of us. But that's the essence of pathology, is just get comfortable describing the thing that you're seeing. And you did such an excellent job. So especially in contrast to the somewhat normal epithelium over here, then you really see the dysmaturation that's going on in this cervical biopsy. So this one, this would definitely be one that I would show and say, would you call this CIN2 or CIN3? And I would do KI67 and P16 to help me make those decisions. You have your little endocervical gland sitting there, but not involved. Yeah. So yeah, I just wanted to go over that because this will haunt you over and over and over again. Any other comments from our GYN experts in?
I remember during the cytology fellowship and when we were looking a lot of cervix, Dr. Harry Gopal would be like, the low grade, it could be a little tricky because it's kind of subjective, but it's like a stop sign. If you want to see it, it has to be like textbook and, it just catches your eye. That's your low grade. Anything below, then you show or just don't call it. So I think setting a threshold and having a mentor guiding you like that is very important. And just seeing a lot many times over and over again, you know.
Let me
Yeah,
let me
that's a great.
share this let me share this slide because I think it illustrates what you've just covered and in a couple of ways. First off, this is not cervix. This is from the anus. And as you can see, it's mostly squamous mucosa with a little focus here over here of some enteric mucosa. But let's just take a look right here and see what people would say about this. So, Tian, do we have any maturation here?
I think we do.
Yeah, we do have some maturation. And then we've got this dyskeratosis on the surface. Let's find another area here. I think we've got some other features. I don't have my good mouse, so I'm having a little trouble moving things here very well. What other dysplastic features do you see here? Like right here.
Mm.
Loss of intracellular bridge.
Well, that's not the thing I was thinking about. But we do have some oops here. Oops, there we go. Let's see how high up I can get this. What are these?
Colossi.
Yes, okay, that's the magic word, koilocytes. And those are characterized usually by very sharp borders to the clear space rather than a fuzzy one. There are sort of pseudokoilocytes that can have sort of a fuzzy clearing around the nucleus. And then the other feature here that I think suggests that this is viral effect is the nuclei are wrinkled and they tend to point in different directions. They're sort of haphazard in the way they go back and forth from one direction to another. So maybe many people, sorry for would call this kind of an area low grade. Maybe in some areas you might find an atypical mitosis and it might be called high grade. But let's just look at one other area over here. Oops, there we go. So what do you think here?
Bowen disease. Linear sign. Bowman disease is a squamous cell institutes.
Yeah. So this is obviously high grade here. So even though we were kind of debating on that other area, is this CAN2 or I mean, is this a intermediate grade or is it low grade? Once you find the diagnostic area, if you keep looking, very often you'll find these other features in at least one focus. And here, this is, I think, a nice example. One of those features that for me always trips it over to high grade, and I don't know if Esther's going to agree on this or not, but for me, when I see an atypical mitotic figure, in other words, a tripolar or rounded mitotic figure in the tissues, I pretty much figured that has to be a high grade dysplasia and move it into the HSIL category. So I thought this slide was just a nice example of kind of both ends of the spectrum and how that if you keep looking, getting deeper levels or whatever it may be, that oftentimes that slide will eventually tell you what it really is.
Mm. Yeah. Yep. So that would be AIN.
That's correct. Yeah, it would be HCell, but anal intraepithelial neoplasia high grade, AIN3.
Yeah, I guess the same criteria and grading and kind of adjusting your eye threshold can apply to any squamous surface lined mucosa, like the ones in your oral cavity or nasal also. So,
Or the
but
esophagus. Yeah,
mhm.
we'll revisit this issue in many places.
Yeah. And we do get some anal pap smears. Sometimes these lesions can be screened. And often these are sometimes incidental findings in hemorrhoids. So tissue is removed for hemorrhoids, but you end up seeing some AIN. So that's also interesting.
Okay. Yeah, great. Mm.
Sorry, Professor. Previous my computer stop not work.
Oh, don't worry. Any other questions?
Hello. Yeah, I have one basic question. I just confusing. So for morphologically, so I know the transition zone is very important for the cervix or the. So I just for the definition of the transition zone is from the original SCG to the current. So I don't know for the for pathology, it's important to see the how can you identify the no, the original SCG. I know it's the SCG is changing along with the age. I just confusing when I start the module for this concept. So I don't know how to because I need to know the transition zone. I know it's the columnar cell and squamous cell. They are the transition area, but how do you do this in the real practice? I just don't know. Curious about.
So let me see if I'm getting your question. You're confused how to report transition zone or how to see it?
No, so in the real practice, we need to identify the original SCG area, the squamous columnar junction, or we needn't just see the current SCG junction, or I don't know the original one is important or not. The original SCG.
I would say that the action is where the squamocolumnar interface is now. It's true that there may have been something at an earlier stage in something, but as a woman ages and that zone migrates upward, it's really at that interface between the two types of epithelium where dysplasias begin and the inflammatory reaction is and so forth. So I don't pay any attention to where, it may have been, except maybe I'd say there's squamous metaplasia because it's covered over endocervical type glands. But unless there's dysplasia, we don't spend much attention at or make any distinction of that location. We do like to sometimes verify that the sample includes the squamocolumnar junction, either cytologically or in a biopsy, because we don't want them to take a negative result as a no cancer when they haven't sampled where the action or the risk is occurring.
Yeah.
Okay.
Yeah.
Thank you.
Good question, though.
So it's 9:04. So if there's no more questions, Any lasting words, Dr. Hassel?
No, this was a great session, good cases and good discussion. Thanks everyone for preparing so well, and thanks Esther for spending the extra time with our two presenters today. And we'll see you again in 2 weeks.
See you again. What are we discussing next time?
Well,
What
it's
module?
tentatively scheduled for still for GYN 1 module.
Oh, okay.
So we
anyone
can do more GYN cases.
Okay, sounds good. All right. Thank you, everyone.
Yep.
Thank
Excellent.
you, Rosa. Thank you.
Bye.
Bye.
Thank you.